So we often explain how anticoagulants work by saying they thin the blood. But in actual fact, anticoagulants don't thin the blood. They slow down the way that the blood clots by the effects the drug has on a mechanism in all of our bodies called the clotting cascade. Now, I'm not going to explain the clotting cascade to you all because it's very complex and, well, it would take me a whole day to explain it. And then if you were like me, you'd probably go away and forget about it because it is so complicated. But we do all have the clotting cascade in our bodies. So blood clots in a person not on blood thinning drugs, if you stuck a pin in your finger, say you stuck a pin in my finger, it would take about 10 seconds for the blood to start to clot. Now, if you were on warfarin, that equates to an INR of 1.0. So if you've got 1, take the point away, you've got the 0, so that gives you 10. So it's roughly taking 10 seconds for your blood to clot. So if you had an INR of 2.0, that equates to 20 seconds, 3.0, 30 seconds, 3.5, 35 seconds. And the higher the figure goes, the longer it takes the blood to clot. So as we would say, the thinner the blood is becoming. The lower the blood goes, the nearer to normal it's getting. So INR targets set in patients on warfarin are to achieve the ideal speed that the blood clots or the thinness of the blood. So for example, if you were on warfarin because you'd had a DVT, your target or that we're aiming for with your INR would be 2.5. So we want your blood to clot in approximately 25 seconds. And the way we do that, as you know, is we bring you into INR clinic, we take your blood, and it used to be very simple the way they checked blood. They used to do it in a baby bath. And years ago on the wards, we used to do it in test tubes on the shelf in the ward. Don't do it like that anymore. It's all done by computer now and on big machines. Although, if we have a high INR, it's checked in what's essentially a baby's bath, and they do it manually with a stopwatch and a baby bath. You know, the plastic ones that we used to use. Anyway, so what they do is they test the time it takes for a light that's shining through the blood to go out. And when that stops, essentially the blood's clotted. And so in the machine, basically that's what they're doing, testing how quickly it takes your time to clot. And then a couple of other factors are added to that, and that gives you your INR, which stands for International Nationalized Ratio. Okay, so long as we know what the cause is, or the reason is that you're on warfarin, there are defined conditions like atrial fibrillation, DVT, mechanical valve replacement, and we have ranges for each of these conditions. And so we know what time we're aiming for. So we do your INR, we have a look how close you are to the target. If you're within the range, so if your target's 2.5 and you're 2.2, that's great. You just adjust your warfarin slightly. But if your INR is too high or too low, we adjust your warfarin to bring the INR back to where we want it. Now, DOAcs can be measured much better due to their predictability. And so we don't check the blood on patients when they're on DOAcs, but what we do check is patients, we do baseline liver, kidneys, and we check those platelets in your blood, and we check your HB, which is the oxygen levels in your blood. And the reason why we do that is so that we can establish a baseline to see where we are at the start of you starting a new anticoagulant, whether it's a DOAC or warfarin. And then with the warfarin, as you know, we do INRs regularly. But with the DOACs, depending on what your renal function is, what your kidneys are doing, would depend on how often we're going to check your bloods. So if you had altered renal function, if your kidneys weren't working very well, we might check your blood every 3 months. If they're working okay, but not brilliantly. We might check them every 6 months. And if they're working very well with no problems, we check your blood every year. And what we're looking at then is the speed that the kidneys are working for the excretion of the DOAC. So the two different drugs work differently. They're both anticoagulants. They both thin the blood or make the blood. They affect the clotting of the blood. Now, warfarin or coumarin, and I'll give you a bit of history about warfarin, if I may, because it's quite interesting. Warfarin was found back in the 1940s, and it comes from a little flower called sweet clover or coumarin. And what happened, there was the Canadian farmers were feeding their cows and changed the feed to a different hay. And in the hay was this little flower, this sweet clover. And what the farmers found was that their cows started to bleed, but they didn't know why. So they commissioned the Wisconsin Alumni Research Fund to investigate what was causing the cows to bleed. So Wisconsin Alumni Research Fund, WARF, they investigated it, and they found that this little sweet clover flower caused the blood to thin. And so they developed out of that then warfarin, and the Wisconsin Alumni Research Fund was given the name. So that's where the name warfarin comes from. Now, in the 1950s, I think it was 1956, Dwight Eisenhower had a heart attack. So he was given warfarin after his heart attack, and he was one of the first people to be treated on it. So for those of you who are on warfarin, possibly you're in good company. But it's quite interesting how it's come about, and was, you know, so many of our drugs that we use today come from flowers, and warfarin is no exception. So warfarin or coumarin is processed through the liver, and it's a vitamin K antagonist. That means it stops the vitamin K working. Now, vitamin K has an important role in our blood clotting, but the warfarin stops it working. And this is why when you're on warfarin, you have to be careful how many vitamin-rich vegetables you eat, because it can have an effect on your INR. We ask you not to eat lots of vitamin K. Some places will ask patients not to eat vitamin K-rich vegetables at all. But a little bit regularly is not a problem. But if you eat too much, like at Christmas, people have spinach and broccoli and Brussels sprouts and they're all on their plate, and it can knock your INR back down to 1.0. It really can affect the warfarin. So warfarin, as I said, is also processed in the liver. Now, that can also cause problems, because another thing that's processed in the liver is alcohol. And so again, this is why when you're on warfarin, we give you very strict information about how much alcohol you could drink. So you can see now where the problems come with the vegetables that are rich in vitamin K, or multivitamins with vitamin K, or the alcohol, where there could be problems there. So warfarin is very restrictive on your diet. And some people struggle because they feel that they have to change their lifestyle to fit in with the warfarin, and that can be quite difficult sometimes. So enter the DOAcs. Now, DOAcs work in a different part of the clotting cascade, and their behaviour is far more predictable, which is why we don't have to monitor the drug so frequently. The organ involved in the process with DOAcs is the kidneys. The kidney function is monitored, as I said, every 3, 6 or 12 months, depending on how well your kidneys are working. And your dose may be altered depending on your kidney function. So you might take a lower dose than perhaps one of your friends who's on it. There are a few diet restrictions, or very few diet restrictions, when taking the DOAC. And the government guidelines should be followed regarding the consumption of alcohol. Adults are recommended to drink no more than 14 units a week, spread across 3 days. So that's around 6 medium glasses of wine or 6 pints of beer a week. But always follow the advice of your clinician Now, some drugs that are prescribed or over the counter can interact with your anticoagulant, and it's very important you inform your doctor or nurse in the clinic if there are any changes in the drugs you are taking. And that includes those drugs that have been stopped as well. So if you've been on something like an antibiotic, not necessarily for a long period of time, but you stop it, let the nurse know next time you go and get your INR checked. If you're starting a new drug, also the GP might put you on something. When you go to the chemist, tell the chemist when you're picking up any new drugs, remind them that you're on an anticoagulant so that they're aware. Now, there could be prescribed drugs that have an effect, but also over-the-counter drugs can interact with anticoagulants. So again, it's important that you tell the doctor or nurse about that. Now, some of those tablets that you buy over the counter might be cough and cold remedies like Lemsip or bitumen powder. We recommend that patients take paracetamol for pain relief. If you need anything stronger than paracetamol, you need to speak to your GP. But even paracetamol taken over a period of a few days can affect your warfarin. So again, mention it to the team when you go in to have your INR checked that you're on warfarin, that you're on the paracetamol. That's really important. And also, if you start on any herbal remedies, there's so many that could potentially interact with warfarin. Anything you start, you need to check with your pharmacist. Two other drugs that can interact with warfarin that you buy over the counter: aspirin. Aspirin is not an anticoagulant. It can cause bleeding, but it's not due to an anticoagulant effect. But aspirin is sometimes found in drugs like, I believe Anodin has aspirin in it. Some pain relief has aspirin. And also Alka-Seltzer. Alka-Seltzer has a lot of aspirin in it. So just be aware when you're buying anything that you know what's in it. Tell the pharmacist so that if you can't take it, then you know you'll have informed them. Well, there is a test. They do peaks and troughs. So they can actually look, but these tests are quite lengthy because of the predictability of the DOAcs, because of the clotting cascade or the part of the cascade that they come on, they're far more predictable in their action. So the thing that we really need to keep an eye on is your kidney function, because they're excreted predominantly through your kidneys. Apixaban is more fecally dispelled, so that goes through the bowels and comes out when you go to the toilet and have a poo. But majority of the DOAC comes out through urine, so it's quite predictable. Now, if you were pregnant, or if there was any concerns that your levels were not where they should be with regard to treatment sort of protection, then they can do these peaks and troughs, but they don't do them in very many patients because of the predictability of the drug, and there's no necessity to do it. So we can do it if we have to, but we don't need to do it because of the efficacy of the drugs and what we know about them.
Thank you. That's
I suppose one of the biggest problems to stand on any anticoagulant long term is there's always that risk of bleeding. In terms of the effects on kidneys or liver, I'm not aware with the long term use that there is any problems. One of the problems, and I think it comes up in a question later, is my clinician said I can stop taking warfarin, but I'm frightened to. And we certainly find patients who have been on warfarin for years and years, and they've just never been approached to stop it. And it forms like a cradle around them, and they're frightened that if they do stop it, then they could have another clot. But in terms of taking it for the long term, I'm not aware of any problems myself that by taking it long term. We don't give warfarin to people unnecessarily because of the bleeding risk. So that's probably the main risk to, as time goes on, you've still got that risk and that risk remains with you. the type of clot that the person's had. Like if you've got a mechanical valve, that mechanical valve isn't going to get, it's not going to change. And the risk of associating a clot while you've got that valve in place is always going to be there. So potentially you're going to be on warfarin for life. The same with patients with atrial fibrillation. Atrial fibrillation increases your risk of having a stroke greatly. Now, the atrial fibrillation, even if it was proximal and came and went, it's not there all the time, the risk of developing a stroke from the atrial fibrillation remains. And so the likelihood is you will be on an anticoagulant for life. Now, with the mechanical valves, you have to be on warfarin. But with AF, there is a possibility that you could be on warfarin or a DOAC. So there is some, if people struggle to take the warfarin because it doesn't fit in with their lifestyle, there is the small light at the end of the tunnel that they could go on to, you know, the DOAC. Now, with the DVTs and PEs, if you have a DVT following surgery and it's a one-off occasion, then the treatment for that is likely going to be 3 months. If you have a PE following a DVT that you got through surgery, or if you were pregnant or from any other risk, and it was a one-off with no other complications, you likely be on that warfarin then or DOAC for 3 to 6 months. If you've had a clot that's come out of the blue with no reason for it at all, you're likely to be considered to stay on longer term, depending on what your risk factors are, what your history is, and other factors that are taken into consideration. If you have clots, if you have one clot following, say, surgery or childbirth, and then go on to have another clot as soon as the treatment stops and you're removed from the anticoagulant, then the likelihood is that you would be put on the anticoagulant for life. It's just weighing up the possibility of you, what your risk benefit is, what the risk of you having another clot is, and also we look at your bleeding risks. So we have to weigh everything up and make a decision whether you can stay on it in the short term or whether evidence from research shows that you need to stay on it on the longer term. If I kicked you in the shin, you'd have a bruise and you'd be able to see it, and it would probably be a black bruise or a black eye if I punched you in the eye. Now, what happens over a period of a few weeks is that bruise starts to change colour and it alters and it gradually disappears. Now, what the warfarin is doing is preventing the clot from getting bigger in your vein, but it's not dissolving it. It doesn't work like that. But what's happening with the clot is the same thing that's happening with your black eye or your bruise on your shin. And it's a process that happens in the body which breaks down the clotted, the clotted blood from the bruise or from the clot in your leg. So that would break down over a period of possibly up to 6 weeks, which is why sometimes people who have had a DVT or a PE, the first 6 weeks, they notice they've still got pain in their leg, or they may still have, you know, some residue from the PE, they might have shortness of breath. But as the clot starts to dissolve, well, it doesn't dissolve, it dissipates back into the body, then the symptoms hopefully should improve. However, if you've had a large clot or it's damaged the vessel, then potentially you could have problem in that in your leg for sure, something like post-thrombotic syndrome. In the veins, we have little valves, and the valves open and close as the blood goes through. So the blood goes through the vein, the valves open. When it's gone through, they shut. So the blood can't drop back through again. But if when you have your clot, it's near one of these valves and it damages it and it becomes a bit like a net curtain, when the valves open, the blood goes through, but it can drop back through again because the valve doesn't shut properly. So it can cause problems like that, and patients can get swollen legs, they can get edema in that leg. And for some people, unfortunately, they can continue to have pain and swelling, and the same in the lungs. You can get some problems, especially if you've got scarring in the vessels, pulmonary hypertension, where you've got like a flow back through the lungs the wrong way. So in straightforward cases, it's quite straightforward, but sometimes it's not straightforward. But if you're concerned, or if you've got swelling for some time after the event, if you've had a clot in your leg, if your leg is still swollen or red, check with your doctor. It could be due to the damage in the vessel. But if you're worried about it, just ask the question, and hopefully they'll explain to you what's happening. I know there are some consultants who, if a patient comes in with an unexplained clot, they will do lots of blood tests. The blood tests have to be done, though, before the anticoagulation starts. So if a patient comes in and is found to have a clot, say, on a weekend, and they're given anticoagulation until they're able to come to clinic to have a scan, then a lot of those tests you won't be able to do because you would get a false result. So if you come into hospital with a suspected DVT, you never had a clot before, they may do some of those tests. Or what they may do is wait until you're due to come off of the anticoagulant, wait for about 4 to 6 weeks after that, do the blood tests then, and that will help them to decide whether or not they want you to continue on the anticoagulant, so restart it, or find out if you've got any particular hereditary disorders like factor V Leiden or protein C or S deficiency. With patients who, and again, it changes from centre to centre. If a parent comes in who's had clots and says, can you check my children to see if they've got factor V Leiden? The chances are that they wouldn't check the children, but they would ask them to recognise the same risks as a person who's not on warfarin. Because even if you had a family member who had DVTs or PEs, and say you came in to have surgery or you came in to have a baby, you're pregnant, you've come in, part of your history is a family history. You say, yeah, well, mum had clots, granny had clots. So if you come in to have a baby, it's possible they might check you to see if they feel you're at greater risk. If you're coming in for surgery, you would certainly be given low molecular weight heparin and blood thinning drugs during the time after you've had surgery to keep you safe from having a clot. But in terms of actually doing the tests, it depends on whether you've started the anticoagulant or not. If you were coming in for a procedure, they would risk assess you, and they would look at the risk assessment. They would look at your age, they would look at your mobility, they would look at any risk factors you've got. So if you were over 60, you've got a family history of clots, then you would undoubtedly have blood thinning drugs. If you were 30 years old, coming into a medical ward with no risk factors, you were mobile, then it's unlikely they would give you any blood thinning drugs. But if that changed, then they may start them. So it's all the risk assessment when you come into hospital is very important because it establishes how much risk you have. As a rule of thumb, anybody coming in for surgery is going to get blood thinning drugs. Medicine, mental health, because patients perhaps coming in for not necessarily procedures, but maybe coming in for respite, although that's unlikely these days. It's usually something like an exacerbation of maybe a chest infection or something like that. Now, when that person is out in the community, they're probably fine, no risk factors at all, but the chest infection increases their risk. So they would have a blood thinning drug. If it was a mental health patient who was in their 30s, was completely active, no risk factors at all, chances are they wouldn't have any thromboprophylaxis at all. They wouldn't be given any treatment. So it's all very much on, while we aim to assess everybody, and not everybody would be given thromboprophylaxis treatment, blood thinning treatment, but the majority of people probably would be. First thing that I could advise is, first of all, have a look at what their INR is. If it's somebody who's on warfarin, we can have a look at their INR. We can establish if they're running very high, perhaps manage it so we can perhaps run their INR a little lower in the range. That's a possibility. Speak to them about, you know, what their periods were like before they came onto warfarin, and just get a bit of a history. If there's nothing I can do at clinic level, then I would ask the gynecologist to intervene, or sometimes maybe the GP could intervene, and then maybe some medication they could give them to help with the problem. But it's sometimes just by talking about it and making some little adjustments, it can help. But again, it depends on the lengths that your clinic can go to provide that kind of help. And if there's somebody there who you can go to sit down and have a chat with, maybe the pharmacists, they'd be useful as well to have a chat with. But if you can't be sorted out at clinic level, then I would say you would need to go to your GP. GP would then decide if they can sort it out, if not, refer you to gynecology. Somebody comes in having had a bleed, whether they've been in a car accident, whether they've cut themselves at home, if they've just started bleeding, like really bad nosebleeds or passing blood from the back passage, vomiting blood, come into hospital, and we do have antidote drugs which can be used. And there's very strict protocols for following those, you know, giving those drugs. And if they are required, then they will be given to reverse the effects of the DOAC or the warfarin. Now, with warfarin, the life, or the half-life we call it, the duration that warfarin is going to work for is more unpredictable again than the DOAC. DOAC, after 24 hours, DOAC's out of your system. It's got a half-life of 12 hours. So after 12 hours, it's starting to lose its effect. Warfarin can last up to 48 hours or even longer. So if you're on warfarin and you had an accident, we give you vitamin K. With the DOACs, they all have their own antidote. And you would come in and be assessed, and it would be decided if you needed that antidote or not. It's like when people come in, say if you've got appendicitis, you need to come in and have urgent surgery. If you fell over and fractured your hip, then you need urgent surgery on your hip. We have to decide whether we need to reverse the anticoagulant to do that surgery. So it's probably slightly worse if you've had trauma and you're seriously bleeding, then that's an absolute immediate sort of antidote is going to need to be given. If you've fractured your hip and you're on a DOAC, depending on how long you were, you know, waiting for an ambulance, how long it was till you came in, how long it was till you seen, and all that time, DOACs don't last as long. So it's again depends on which anticoagulant you're on and what the situation is. But we do have antidotes for both of them, for all of them, which can be given as necessary. Anticoagulants can affect the fetus, so it's very advisable not to get pregnant. If you do want to get pregnant, go and have a chat with your GP, who should put you in touch with the either the midwives or the obstetrician at your local hospital, and they will be able to manage it for you. Now, it is possible to get pregnant while you're on an anticoagulant. It is you would need to be monitored, and you would need to have the services of an obstetrician to go through it with you. So you need, in the first stage, if you decide, I think I want to get pregnant, have a chat with your GP, and your GP should refer you into the obstetrician. Unless your GP is very good and experienced, then they can arrange it. But I think they would probably refer you to the obstetrics clinic in the first instance. And of course, it also depends on why you're on the anticoagulant. I mean, if you're on an anticoagulant because you've had a DVT, and it's the first one you've had, and you had it after playing hockey, got whacked in the leg by a stick, you're probably only going to be on the warfarin for 3 months. So you could wait till you come off the warfarin and start your family when you're off the warfarin. If you've had a mechanical valve, there may be other complications which could affect you having a child, which are other things you need to take into consideration. But obviously, we can't just take you off the warfarin or the DOAC so that you can get pregnant. So you need to speak to your doctor first and then take advice from them about how you go forward. Okay, well, what we do is we provide bridging, and bridging is where we stop your warfarin. Warfarin's more difficult or more complicated to bridge than a DOAC. With the DOACs, it's quite straightforward. Depending on the procedure you're coming in for, we stop the DOAC either 24, 36, or sometimes 48 hours before the procedure. And then once the procedure's been done and the risk of bleeding has subsided, you can then restart the DOAC. With warfarin, it's a little bit more complicated. We stop the warfarin 5 days before the procedure. After 2 days then following you've stopped the warfarin, some services will check your INR, some won't. And when you come to that day 2 having stopped, which is 3 days before your procedure, we change you over to low molecular weight heparin. So we counsel you, we go through everything, we have a look at what procedure you're having done, we check your weight, and we'll put you on to a low molecular weight heparin, which is the little injections you have in your tummy. We put you on that for 2 days on full strength low molecular weight heparin. So that's keeping you safe from having a clot or whether it's AF or DVT. Even if you've got a mechanical heart valve, we can still bridge you. So you have the dose for 2 days, and then the day before surgery, you have a lower dose, which reduces the risk of bleeding on the day. You come in then, we bring all our patients in on the day. We don't bring anybody in the day before unless it's absolutely essential. You have your procedure done. Generally, if it's safe to do so, we would restart, we'll give you the low molecular weight heparin that evening, either at the full dose or a half dose, depending on the bleeding risk. Depending again on the bleeding risk, they might restart your warfarin that evening. If there is a high risk of bleeding, they might not give you any anticoagulant on that day. They might give you a half dose of an injection on that day, or they might leave it until the following day and then start then. It all depends on the surgery you've had and what your bleeding risk is, because we have to weigh up the bleeding risk against the clotting risk. No good protecting you from having a clot and then you, well, bleed everywhere. So it's all very well sort of planned and organised so that we keep you as safe as possible from either bleeding or developing a clot. And generally, hospitals have a bridging service to do that. So it works very well.
Thank you. So really, for the vast majority of patients, no matter how big or small the planned procedure is, it can still proceed, but there will be conversation. And I guess what you're saying is you'll be managed on an individual level to make sure you are the safest against all of the known risks that are recognised within your care. Okay, that's really helpful. And that goes across dental health, investigations, as well as...
Dentists are a little bit different because they don't come under the hospital unless if you've got a dental hospital attached to your hospital. Dentists do have their own guidelines, but occasionally you get patients ringing up saying, I've got to have a tooth extracted. My dentist doesn't know what to do. What should I do? Well, they do have their own guidelines, but patients can get a little bit fraught. And it's quite difficult because we can't always intervene because we're not involved with the patient's care. But things like if you're coming in for a biopsy, just if you're coming in for a hysteroscopy, anything like that, we can manage the warfarin or the DOAC to however is decided it's safest to keep it during that time. Yeah, well, we've all had to sort of deal with this. I guess one way to do it is keep your medication on British time zone. So take a second watch with you and use that as your medication times and take them as accordingly. Unfortunately, it may be that you've got to take them at 3 o'clock in the morning. So that's a little bit awkward. Try and manage it in such a way. If you take your warfarin normally, we recommend patients take the warfarin in the evening at tea time. And the reason we ask people to take it at that time is because if we had to ring you later in the day after you'd had an INR done and your INR was high, we've got all day to get hold of you to tell you to stop the warfarin. But if you take it in the morning, then you've already taken it for that day, so we can't stop it. And if you've already got a high INR, it's not going to help. So if you took your warfarin at, say, 5 o'clock in the evening every day, what you could look at, what time is 5 o'clock in the evening where you're going. Now, it might change that 5 o'clock in the evening where you're going becomes 11 o'clock in the evening or 7 o'clock in the morning. So you could either take it at that time while you're away in that place, because you know that's the same time. And when you come back to the UK, you just go back to your original time. I think you need to look really and see what the time is that the place you're going to. Now, you might need to alter it an hour either way, so you're not going up at silly time in the morning or going to bed ridiculously late. So you might have to bring it back or move it forward an hour. And I think that's acceptable. But have a look at where you're going and then work it out accordingly. And most places, I mean, if you're going across to Europe, we're only an hour ahead, it's not too bad. I think America is 6 or 7 hours. I'm not sure if that's ahead or behind. So just look at a time that you can either swap it to in that country that matches the time you're taking it in this country and change it over, or keep on the same time but have a separate watch so that you know on that watch what time it is, and that's when you've got to take it. We're always looking at what's happening. We have real life data, so that's looking at thousands and thousands of people. One of the areas that we are particularly looking at is people who are large body mass. So when the DOAcs first came out, the maximum weight that you could give a DOAC to was 120 kilos. Well, now we've gone beyond that because research has shown us that it is safe to give to patients. You might have to adjust the dose, might have to give a BD dose, but we can give it to patients now who are in excess of 150, 200 kilos. What we used to do with larger patients who wanted to go on DOACs, we do the peaks and troughs that I was talking about to see if their INR, well, it's not their INR, to see if their blood was in the right place. But there's studies going on all the time looking at these drugs and their efficacy. And I guess in time, the hope would be that we would be able to put patients with all reasons for being on warfarin, whether it was a mitral valve replacement all the way through to DVTs and PEs. And because of the real world data they're collecting, and they can see what's happening like in the shop floor, so to speak, it gives us reassurance in using these drugs, and also hopefully bringing new conditions in line with, you know, putting people onto what I suppose you would consider more sociably acceptable anticoagulants rather than warfarin.
No, thank you so much, Andrea. That was really informative, very helpful. I can see from the chat how many people are saying thank you. Really
Thank you all very much.
Thank you so much. Okay, bye-bye.